So stage 4 metastatic pancreatic cancer, nearly 50% of the patients with the pancreatic ductal adenocarcinoma have metastasis at the time of diagnosis. In stage 4, they remains poor. Prognosis is poor with a median OS of around 8 months. And the 5-year survival rate is 3%. And there have been modest improvement in the survival. The first-line multi-agent systemic therapy in sequence. Second-line regimen metastasis can often be controlled after 8 months or more. These agents are older, non-targetable cytotoxic chemotherapy, and this should be regarded as significant advancement given the histologically poor outcome in patients with metastatic pancreatic ductal adenocarcinoma. Implicit in this discussion is the principle that locoregional therapies, including dissection and radiation, have limited to no role in patients with metastatic pancreatic ductal adenocarcinoma, except in the rare palliative scenario. We discuss here the evidence supporting the current first-line, second-line regimen. So, first-line regimen is gemcitabine. It is a dinucleotide analog of deoxycytidine, and it is administered as a prodrug, and upon entry into cell, gemcitabine is phosphorylated by deoxycytidine kinase DCK to monophosphate form DCMP, and similar to the association between thymidine phosphatase and the prodrug capecitabine, elevated DCK level in tumor cells compared to normal are believed to enhance the therapeutic window of gemcitabine, and DFDCMP is then phosphorylated into active diphosphate and triphosphate forms, and the active metabolites incorporate into DNA and inhibits elongation. They deplete nucleotide pools by competitively inhibiting ribonucleotide reductase. So 5-FU was the preferred treatment historically in case of metastatic pancreatic ductal adenocarcinoma. Outcomes were poor with response rate less than 20%, survival approximately 6 months, nearly equivalent to best supportive care. So Barish and colleague, they randomized this 126 patients of advanced pancreatic cancer, received gemcitabine 1000 mg per meter square weekly for 7 weeks, followed by 1 week of rest, and then weekly 3 doses every 4 weeks thereafter. And bolus 5-FU or bolus 5-FU 600 mg per meter square weekly, and patient primarily had metastatic disease. 26% had locally advanced, and treatment of both the arms were generally well tolerated. Grade 3 for hematological toxicity higher with gemcitabine, like neutropenia, thrombocytopenia, anemia. They were more frequent with the gemcitabine. Clinical benefit based on pain score, performance status, weight. They were noted 23% in the gemcitabine and 4% in the 5-FU. Survival advantage with gemcitabine just over 5 weeks. Median OS 5 and 4 months. So partial tumor response were observed in 5% of the patients with the gemcitabine group and stable 39%. So no partial tumor response were observed with 5-FU, and only 19% patient experienced stable disease, and as a result gemcitabine was approved by FDA in 1997 as a first line treatment for locally advanced unresectable metastatic pancreatic cancer. So this is important. Gemcitabine was approved by FDA in 1997 as a first line for locally advanced unresectable metastatic pancreatic cancer. And there were 2 studies examining dosing and infusion of gemcitabine to increase the intracellular concentration. So Tempero et al. Conducted phase 2 trial of 92 patients of advanced metastatic pancreatic ductal adenocarcinoma. 30-minute infusion of gemcitabine to 2200 mg per meter square or 1500 mg per meter square fixed dose rate of 10 mg per meter square per minute of 150 minutes. And those who received fixed dose rate had improved median OS. Pharmacokinetic analysis showed twofold increase in the intracellular concentration of increase in intracellular concentration with the fixed dose rate. So 10 mg per meter square per minute over 150 minute, that is fixed dose rate. It was associated with a higher grade 3 for hematological toxicity. Comparing the gemcitabine oxaliplatin, so patient with metastatic local study confirmed that increase in OS with fixed dose rate with 30 minute compared to 30-minute infusion of gemcitabine. But those who received fixed dose rate had greater grade 3 for neutropenia, thrombocytopenia. Patient who received gemcitabine oxaliplatin did not have improved survival compared to either of gemcitabine alone. So negative gemcitabine combination trials like GEMOX trial testing gemcitabine doublet including cisplatin, 5-FU, capecitabine, irinotecan, exatecan, all have failed to demonstrate any OS benefit compared to gemcitabine monotherapy, and despite a lack of general overall survival benefit, combination of gemcitabine cisplatin GemCis that is applicable in patients with advanced metastatic pancreatic ductal adenocarcinoma and known mutation of BRCA1/2 PALB2. So gemcitabine 600 mg per meter square, cisplatin 25 mg per meter square on day 3 and 10 with or without PARP inhibitors paliparib 80 mg orally twice daily on day 1 to 12, cycled every 3 weeks in patient with untreated advanced metastatic with BRCA1/2 PALB2 germline mutation. Median PFS with GemCis was 10 months and without PARP inhibitors, and OS was 15 months. Trial examined gemcitabine with capecitabine failed to demonstrate improved OS, but this trial demonstrated patient who received combination chemo had improved response rate and PFS. Overall survival was improved in patient who received combination gemcitabine with 5-fluoropyrimidine compared to gemcitabine mono. And several trials biologic therapy in combination with gemcitabine. So studies examine metalloproteinase inhibitor, tipifarnib, KRAS signaling inhibitor targeting KRAS, cetuximab, exitinib, elpamotid, masatinib, regosertib, combination with gemcitabine all show improvement in OS as compared to gemcitabine alone. Biological therapy. Gemcitabine plus albumin bound paclitaxel. So albumin bound, that is nab-paclitaxel, is a nanoparticle form of paclitaxel, binds to high affinity microtubules and thereby stabilizing tubule polymerization and inhibiting cell mitosis. This nanoparticle formulation results in improved pharmacokinetic efficiency and 33% higher intratumoral drug levels compared to the standard solvent-based paclitaxel formulations. So in case of pancreatic ductal, gemcitabine 1000 mg per meter square with nab-paclitaxel 125 mg per meter square every weekly for 3 or 4 weeks. It resulted in response rate of 48 months and median OS 12 months. So MPACT trial, it was based on the MPACT trial. Nab-paclitaxel with gemcitabine. So results of this MPACT study, they resulted in FDA approval of the nab-paclitaxel in 2013 and a second agent indicated for combination therapy gemcitabine, and this regimen is considered one of the modern first line treatment for advanced metastatic adenocarcinoma, gemcitabine with the nab-paclitaxel. Then EGFR is an oncogene expressed in 60% of the patient with the pancreatic ductal adenocarcinoma and therefore is a reasonable therapeutic target. Additionally, targeted EGFR in certain non-pancreatic like lung, colorectal, head and neck, and several trials have tested anti-EGFR therapy. So first is cetuximab, which is a monoclonal antibody affinity for EGFR. So patient with 41 patient EGFR positive, median OS of 7 months with 1 year overall survival 31 months. So there is potential benefit when compared to historical control. SWOG study did not this combination did not improve outcome compared to gemcitabine alone. Response rate, PFS, they were all similar. Then erlotinib, second is erlotinib. This is tyrosine kinase inhibitor that blocks EGFR. So NCIC CTG trial. Combination gemcitabine or erlotinib becomes standard of care as a first-line treatment in locally advanced metastatic patients with reasonably good PS status at many centers. Erlotinib adds roughly something dollar per month. Gemcitabine or erlotinib is clearly more effective in small group of patients. No specific biomarkers have effective in select patients with this trial. FOLFIRINOX, French phase 1 FOLFIRINOX patients with metastatic solid tumor were reported. So this finding led to this prompted initiation of phase 2 FOLFIRINOX to gemcitabine that continued as phase 3 as PRODIGE 4 COD 11. So this trial showed that FOLFIRINOX group as compared to gemcitabine alone. So FOLFIRINOX resulted in a substantially more toxicity, including higher grade 3-4 neutropenia, febrile neutropenia, thrombocytopenia, sensory neuropathy. So despite this side effect, there is 31% FOLFIRINOX group had definitive degradation in the quality of life as compared to 66% in the gemcitabine. And also there is definitive deterioration was also significantly longer for the FOLFIRINOX group. So critical trial includes strict eligibility criteria limiting generalized review, but FOLFIRINOX is recommended as the first line treatment in patients with good PS. So given this toxicity, FOLFIRINOX studies have conducted on modified regimen good and FOLFIRINOX with received FOLFIRINOX with 25% dose reduction in bolus 5FU, and irinotecan demonstrated comparable progression-free survival as NOS. Studies of FOLFIRINOX, modified FOLFIRINOX, and gemcitabine with nab-paclitaxel as the first-line treatment for metastatic pancreatic ductal adenocarcinoma. This is the model. Modified FOLFIRINOX, modified FOLFIRINOX, and gemcitabine nab-paclitaxel. 2. They are the preferred first-line treatment of patients with metastatic pancreatic ductal adenocarcinoma.